Good evening, everyone, and thank you for joining this session. So, we'll start with a story, and you are in the night shift. It's 12:30 in the night, and you get the case. 52-year-old gentleman who's a known case of hypertension is coming with chest pain, and he reports that there is some radiation to the back. It's not a very severe type of chest pain. Maybe it's about 3 or 4 out of 10 in terms of severity, not very severe. So you do a primary survey, and there's nothing particularly wrong there except for a BP, which is kind of elevated, 173 or 102. Just a systemic examination is within normal limits. There is no audible murmur as such that you can appreciate. So what do you do next? So you obviously chest pain patient, you get an ECG done. This is the ECG, and there isn't anything really special about the ECG that really moves your treatment decision pathway one way or another. You do a troponin. Troponin comes as a negative. So the question now is, what do you do next? So your patient is coming with chest pain, with some radiation to the back. It's a known case of hypertension. ECG is negative, tropa is negative. So one of your colleagues suggests that this could be aortic dissection. So the problem you now face in the middle of the night is how to proceed. So you ask your friends around you and they give you multiple answers. So you ask your coach JR and he says that he has read about the score called the address score and he thinks that might help us out rule the patient in or out of aortic dissection. You ask your SR and he says maybe you should try doing a D dimer and see if that comes as a negative. Maybe you can rule out the patient after a negative D dimer. And your radiologist friend says maybe you should do an X-ray and see. But whatever it is, don't send the patient for CT or anything. That is what he basically wants to say. So there's a lot of confusion here. And in this lesson, we'll try to address some of these confusions. So this is a talk on aortic dissection, which is one of the most frightening conditions that can come to your emergency department. So why is it frightening? One, because it has a very, very high miss rate. So as per certain studies, up to 40% of the cases of aortic dissection that presents to the ED is actually missed. You do not actually diagnose it initially. And it is very, very dangerous. So if you don't actually treat it properly, it has a mortality rate of up to 70% in the first 2 weeks, depending on the type and all. So it's not good. So it is difficult to diagnose and it is pretty lethal. So that is a very dangerous combination to have. What exactly is an aortic dissection? So aortic dissection is basically because of a uh, problem with the tunica intima. There's basically a violation, a hole inside the tunica intima. And through that, the blood starts seeping into the tunica media. And it starts propagating or, dissecting between the tunica intima and the adventitial layers. That is what forms your aortic dissection. So you have a hole in the tunica intima, and that leads to blood dissecting through the tunica media in between the other two layers, the intima and the adventitia. So there are classifications. There's a DBAK classification and a Stanford classification. You have DBAK types 1, 2, and 3. DBAK 1 is basically a dissection involving both the ascending and the descending aorta. Type 2 is basically confined to the ascending aorta, whereas type 3 is basically only the descending aorta distal to the left subclavian. So that is type 1, 2, and 3. But the main classification we use clinically for the management of patient is the Stanford classification, which consists of the type A and type B. Type A basically anything that involves the ascending aorta is type A, and anything that is confined only to the descending aorta distal to the left subclavian is type B. So epidemiology, very, very simply, it tends to happen more in the older age groups once you get, damage to the walls of the aorta due to long-standing hypertension, which is the main risk factor. It's more common in males in ratios of around 2:1. Coming to risk factors now, similar to MI, these risk factors are more important in younger patients. It can significantly increase the risk of dissection in younger patients compared to older patients. So one is any kind of structural abnormality of the aortic valve. So any kind of aortic aneurysm, bicuspid aortic valve, or some kind of syndromes like Turner syndrome, Noonan syndrome. So any kind of structural abnormalities of the aortic valve that can increase your risk of a dissection. Iatrogenic. So any kind of cardiac intervention as such on the heart can increase your risk of dissections. This is why cardiologists tend to take a lengthy consent from the patient explaining all the risks before taking a patient to the cath lab. Weak connective tissue. So any kind of weakness to the tunica media will obviously increase the risk of aortic dissection. And most important cause here is going to be Marfan syndrome. 5% of patients with Marfan syndrome end up having an aortic dissection at some point or the other, and 50% of all aortic dissections less than 40 years of age are related to Marfan syndrome. So Marfan syndrome is something that should really make you think about aortic dissection, and various other diseases are also mentioned here. And any kind of vasculitis involving your big vessels that can also lead to aortic dissection. How does this present? So number one is going to be pain. So 95% of these patients will present with chest pain, which is usually acute onset, abrupt, and it is usually most severe at the onset of the pain. Where something like angina, where it's like slowly progressing over a few days, then it gets really bad when then the patient presents to the hospital. This is like really sudden onset, and the pain is maximum at the beginning itself. So kind of similar to what happens in your headaches in SH. Tearing or a ripping type of pain, the positive likelihood ratio of this is like plus 10, which is like pretty good. Anything more than 6 of likelihood ratio is pretty good for diagnosis. Migratory pain basically is going to be radiating to your back. So that is seen in about 15% of the cases, likelihood ratio of plus 7. Severe pain is seen in 90%. Usually chest back or even the abdomen can be seen. So chest pain, acute onset, very severe at the onset, radiating to the back should make you start thinking of aortic dissection. So 95%. So there are 5% of cases which have painless aortic dissections, which is obviously going to be much, much more difficult to actually diagnose. So for example, if the patient is presenting with altered sensorium, obviously they might not be able to communicate to the patient that they are having chest pain. Certain people like older individuals, patients with diabetic neuropathy, etc., maybe they are not able to sense pain as well. And so these patients will be at higher risk of painless presentation. And obviously, that becomes much more difficult to diagnose, and this is already a very difficult thing to diagnose anyway. Syncope occurs in 5 to 10% of the cases. Remember that aortic dissection is not a common cause of syncope. So for all the cases of syncope that you see on a day-to-day basis, aortic dissection is going to be a very rare cause of syncope. But in all causes of aortic dissection, around 5 to 10% cases will present with syncope, and it is more common in type A compared to type B. Then you have ischemic manifestation. What you need to remember is neurological symptoms, especially in type A. This can fool you and make you go down a different pathway of diagnosis. So patient can present with something like stroke symptoms. They can present something like transverse myelitis with with the paraplegia of acute onset. Can have Horner syndrome. They can present with an occlusion MI, which will come into. Limb ischemia can occur if it dissects very distally. Mesenteric ischemia can occur, leading to ischemia of the gut, leading to all kinds of problems associated with that as well. So these are the various types of manifestation that can occur with aortic dissection. So what are some of the clues that you can get from the physical examination? So one is hemodynamics, hypertension, more common with your type B dissections. Hypotension is more common with your type A dissections. TP differential, something that we are all very familiar with from MBBS. So a more than 20 systolic blood pressure difference between your arms is considered as significant. The problem with this is that it is not very specific and be seen in up to 20% of normal people also. Gross absence of a pulse is less sensitive, but it is more worrisome for an actual dissection. So if you have gross absence of pulse on one side, but not the other, then that really does increase the risk of having an aortic dissection. And other things that focal neurological deficits or an ischemic limb, etc., that can also be found on examination. So another thing that I mentioned, didn't mention here, is that you can have features of aortic regurgitation also. So you might have an early diastolic murmur of aortic regurgitation. So how can focus help you with the diagnosis of aortic dissection? So there is something called speed protocol. What do you mean by speed? Speed is sonography protocol for emergently evaluating dissection. It has been shown to have a sensitivity and specificity both more than 90%. So this is something that you should consider implementing in your patients with suspected aortic dissection. So basically, it's very simple. You have three components. One is pericardial effusion, specifically your parietal sternal long axis view, which is what they described in this study. Aortic outflow tract diameter of more than 35 mm. Remember, the aortic outflow tract diameters can vary anywhere between 24 to 40 mm, depending on where you actually measure it. So this particular protocol, they went for an in-between cutoff of around 35 mm. And the most specific thing here is like an intimal flap. Anytime you see an intimal flap within the aorta, that is always abnormal. That is a dissection. So these are some images of the same. So in the upper image one, you can see a pericardial effusion associated with an aortic dissection, and sometimes you can see some clots in the effusion as well, because this is basically blood accumulating when you have an effusion associated with an aortic dissection. And below you can see a dilated aortic outflow tract diameter, as well as you can see in intimal flaps as well. So this was a case of aortic dissection that you can easily diagnose on point of care ultrasound. So these are a couple of cases that we actually saw in our center. So this was a case of a type A aortic dissection. So you can see a very gross dilatation of your uh, aortic outflow tract here, and you can see an obvious intimal flap also on the aorta. So this was a type A dissection. Patient was actually presented with severe shock. This was another case. This is actually a type B dissection. So if you look at the abdominal aorta closely here, you can see a flap here. Now you can see a flap here, and you can see a mural thrombus also inside. So this was a type B aortic dissection, and this was actually had a very severe presentation despite the very subtle ultrasound findings. Patient presenting with complete paraplegia, and the patient also ended up having AK due to decreased perfusion to the kidneys and leading to hyperkalemia and eventually went into cardiac arrest. So despite the focus findings being kind of subtle, it was like a very severe clinical presentation. Other findings on focus that you can look for, one is fluid in the abdomen that usually signifies some kind of rupture somewhere, and left sided pleural effusion. This is can also be seen in rupture, and if that happens, generally the prognosis is very bad. That means it's going to be very difficult to control. If you have the skills to look for aortic regurgitation, that is another thing you can do. You can see gross aortic regurgitation here in this image, which I downloaded from the net actually. So you can see gross AR here. So if the AR jet is occupying more than 65% of the aortic outflow tract, that is considered a severe AR, which that is in this case. So that is all about focus. So specifically remember the speed protocol, the three things in the speed protocol: the pericardial effusion, the aortic outflow tract diameter being more than 35 mm, and an intimal flap. So these things will help you to rule in or rule out aortic dissection. What about labs? So D-dimer, this might be something that new that you are hearing. So D-dimer can be used to help rule out aortic dissection. It has a 95% negative predictive value, and it is part of the address score for ruling out aortic dissection. But you have to remember that this is only useful in patients who are having in whom you have a low clinical suspicion of the patient actually having an aortic dissection. If the clinical suspicion is actually high, the PD dimer might be falsely negative, then you might miss a huge diagnosis. So if the clinical suspicion is high, then you will obviously go for CT angio. No, you will not go for D dimer. Labs for complications, some complication you can have increased lactate and abdominal pain. Maybe that's a sign of a mesenteric ischemia. Obviously, you can have AKI, like the example I told you earlier. So these patients can have rapidly progressive renal failure. Rhabdomyolysis can occur, and they can have bleeding as well. This should necessitate massive transfusion. ECG. ECG, most of the time, is going to be non-specific. Most of these patients will have long-standing hypertension, so don't be surprised if you see LVH on the ECG. That is fine. 2% of these cases will actually present with an occlusion MI, and most commonly, it will involve your RCA. So this is a patient who had chest pain. ECG was done, and it looked like an RCA occlusion. So you can see ST elevations into 3 AVF, more in 3 compared to 2, with ST depression in 1 and AVL, and ST elevations in V1 and V2, pointing to a pretty proximal RCA occlusion with significant RV infarction. So this actually turned out to be an aortic dissection. So why does this occur? Why is RCA tend to be involved? Well, if you see the jet going from the LV to the aorta, it goes somewhat towards the origin of your RCA. So if you have a dissection starting from here, you have an intimal violation here, and blood is dissecting. Blood usually dissects upward, away from the heart. But sometimes the dissection can occur and propagate proximally, go into the RCA, and the dissection flap, as it bulges out, it will completely occlude the RCA. This will lead to an occlusion MI, and this will lead to RVMI. And these cases are obviously very, very difficult to manage. So ECGs, you have to be wary about RCA involvement, because that can be a rare manifestation of aortic dissection. Coming to X-rays, there are a few X-ray findings that are quite typical of a dissection. One that you must be knowing is mediastinal widening more than 6 to 8 centimeters is considered as significant. Sensitivity is, however, poor. It is only around 60%. Why it is poor, we'll come to in a little bit. Aortic knuckle may be irregular wide, and basically aortic knuckle looks abnormal due to some reason. Doesn't look normal, basically. Displacement of the aortic calcification towards the middle of the aorta. So basically, in a little patient with some kind of aortic aneurysm, some kind of aorta dilatation, there can be calcification, but calcification will be on the wall. So it will be very peripheral part of the aorta. If it is displaced inwards, that is a sign of aortic dissection. So, and more than half a centimeter displacement inwards is considered significant. Very, very subtle thing to notice. Left side proliferation, again, similar to what I said earlier, it is a sign of either a rupture or maybe some kind of exudative effusion in reaction to the inflammation. So this is a patient, a 64-year-old gentleman coming with mild chest pain. So can someone mention what the findings are on this X-ray? Please type it out in the chat box, or you can just unmute yourself and say also what is abnormal on this X-ray. What do you think is abnormal? Loss of AP window. So if you see, there is one positive finding here and one negative finding, and both are important. One thing is that you see the descending thoracic aorta here. It looks kind of enlarged and elongated. The descending aorta looks enlarged and elongated. But if you look on the right side, the ascending aorta is not enlarged. Descending aorta looks enlarged, but the ascending aorta is not enlarged. And this is an X-ray pattern which is very typical of type B aortic dissections. Type B as aortic dissections, which is what this turned out to be. So this is show the CT. You can see the flap is on the descending part, not in the ascending, but on the dilatation seen in the descending thoracic aorta. So this is seen in type B dissections. Type A dissection, 18-year-old with Marfan syndrome. This is an aneurysm actually, not a dissection. You can see the ascending aorta dilatation with the white arrows here. So this is aortic, ascending aorta dilatation, which is also seen in CT. Another case, again, you see some dilatation of the ascending aorta, and you can see dilatation and a dissection flap on the CT. So these are some of the typical X-ray findings that you can find. So we have another case here, 55-year-old female coming with the short of the breath. So what is seen in this X-ray? Please type it out. What do you think is abnormal in this X-ray? You can just type it out in the chat box. What do you think is normal, or maybe you feel the X-ray is normal also, but you also know. Okay, dilated ascending aorta. Dilated ascending aorta. Okay, that I agree. It looks it can look dilated here, but there's another problem here, which is that this film is actually rotated. The spinous process of the vertebra should be equidistant from the medial ends of the clavicles, which it is not here. Equidistant nahi hai. So there is some kind of rotation here. So this is a rotated film, and that this can fool you, and this can actually send you down a wrong pathway, which is actually what happened on this particular patient. So this was actually the ECG of this patient, and you can see this looks like a pretty significant inferior wall MI, and there's some lateral wall escalations as well. And patient was going into failure basically. But because of this X-ray, somebody decided that instead of emergently reperfusing the patient should be sent to the CT scan. Patient had cardiac arrest in the CT scan and could not be revived. So remember, whenever you have MI, most of the time it's not going to be aortic dissection related. And so you should, generally try to treat it as MI unless you have some pretty significant reasons to think otherwise based on your point of care ultrasound. Because, if you try to send these patients to CT scan instead of, treating them, they might end up having very, very bad outcomes. And this again shows the problem with relying too much on your X-ray findings as well. So medial channel widening might not always be there because sometimes the bulge from your false lumen might go inside into towards the lumen and not actually outside. So if it just bulges inwards inside the lumen, there won't actually be any medial channel widening. If it bulges outwards, then you actually will get medial channel widening. So this is why X-ray might not always show medial channel widening, and that is not something that you should hang too much of your hat on. So, now coming to address score, what do you mean by address? It is aortic dissection detection risk score. It is quite simple. Basically, it has only three things. One is predisposing factors, risk factors. We already discussed various risk factors: Marfan, family history of aortic disease, any kind of recent aortic manipulation, etc. Pain features: abrupt, severe, dripping or tearing type of pain. And exam findings: pulse deficit, BP differentials, focal neurological deficit, no AR murmur, all of those things. So you have risk factors, you have features of the chest pain, and you have physical exam findings. Any of the column is positive, you get 1 point. So obviously maximum you can get 3 points, minimum you get 0 points. 0 is considered low risk, 1 is considered as intermediate risk, and 2 or more than 2, you have to get CT. So that is how the score works. So if the score is 0 to 1, what do you do? So if you can have a score is 0 to 1, but your maybe your history is like really making you think that this could be an aortic dissection, then just get a CT, because you don't. If you really think that the number one diagnosis for the patient is going to be aortic dissection, you should get a CT done. So there's no question about that. If your clinical suspicion is low, if you think that maybe it could be dissection, but I don't really think so, then you can consider getting a D-dimer along with doing your ultrasound speed protocol. If both are negative, then you can rule the patient out without getting a CT scan. So this has been validated in a study. I think it was done in 2017 or so. Negative D-dimer plus address of 0, negative predictive value of more than 99%. A score of 1 with a negative D-dimer, almost a score, almost 98%. So combining these two are pretty good when your address score is low, 0 to 1. Initially, ASAP did not recommend using these scores or using D-dimer until 2025. As per recommendations in 2025, they have given a level B recommendation where you can rule out dissection by combination of address less than or equal to 1 plus a negative D-dimer less than 500. But they have again stressed here that D-dimer alone is not to be used as a rule out test. So you cannot just do a D-dimer alone and then rule the patient that way. That is not recommended. So as per the latest ASAP guidelines in 2025, you can use this approach. Coming to radiology, the main imaging of choice is going to be your CT angio. Okay. The other options are also there, but it's not really going to be feasible in an emergency department most of the time. And you can see the dilatation of your aorta with the dissection flap as well. So one question which is not very important for emergency physician but might get asked in exams based on your examiner is, how do you differentiate between a false lumen and a true lumen? So you can see the descending aorta and the flap there. Usually, the false lumen is bigger than the true lumen, as it is here in this case. The true lumen is usually going to be more brighter due to the contrast compared to your false lumen. And number three, the false lumen will usually adhere to the outer wall of the aortic arch. So more towards the outer side of the aortic arch, you are likely to find the false lumen rather than the true lumen. So generally, it is based on the combination of all of these findings that you say whether one is the false lumen or one is a true lumen. And for us, basically, we are not very interested in this. We are just interested in whether there's an aortic dissection or not. Now, coming to management. So we have some clinical targets that you have to be aware of while managing aortic dissection. So you have something called anti-impulse therapy, and you will target a low systolic blood pressure of around 100 to 120 and a low heart rate of less than around 60 to 70. With the caveat that if a patient is having severe AR and the patient is having AR for some time, maybe they might require a higher heart rate to be clinically stable. But in general, this is what is recommended in patient with aortic dissection. And practically, this is one situation where a patient with hypertension, you should try to put an arterial line earlier rather than later, because you want a very good titration of your blood pressure medications. For that, arterial line is kind of a must here. In other causes of hypertension, other hypertensive emergency, maybe not. It's you can probably get away without an A line, but in aortic dissection, if you have it available, you probably should put an arterial line in this type of patient, even in the ED. Make sure that patient has adequate end organ perfusion. Again, shock is always a clinical diagnosis. Make sure the patient is having normal sensorium, adequate urine output, etc. And patient is pain-free. If the patient is having active chest pain, that probably means that the patient there is still significant dissection. The patient dissection is probably still propagating, so you want to address that as well. So how do you reduce the heart rate? You have different agents. Mostly beta blockers are recommended. You have esmolol. Esmolol is nice because it is pretty easily titratable, rapid on, rapid off kind of effect. Another option is labetalol. Labetalol is good because it can help to reduce the BP as well, not just the heart rate. So it has a double benefit there. Other things, if you have neither available, maybe you can consider metoprolol. If beta blockers are completely contraindicated, then you can consider using tildiazem. Vasodilators can be added to reduce the BP more and keep it in the target range of less than 120. Clevidipine, nicardipine are recommended, but these drugs are generally not available in India very easily. After around 24 hours of management, then you start transitioning to oral antihypertensives. You can add something like metoprolol or carvedilol or oral labetalol as well. Metoprolol will just reduce the heart rate. The other drugs will help to reduce the blood pressure as well. Now, that is all fine. That is the most common management that we do for most of the aortic dissection patients. But what about the hypotensive aortic dissection, the aortic dissection with shock, which is like really, really scary? So you have to know the differential diagnosis for a patient with aortic dissection having shock. Number one is pericardial effusion leading to tamponade. Number two is what you already discussed, which is an occlusion MI, most commonly in the RCA, that is leading to shock. Number three is rupture. So you can see a rupture into the left pleural cavity here. Again, very bad. And number four is you can have bowel ischemia leading to sepsis and septic shock. So these are some of the differential diagnoses that you have to be aware of in an aortic dissection patient coming with shock. So other causes may be there. For example, you can severe AR can present with a low map. You can have pseudo hypotension where you are actually measuring BP in the limb with decreased blood flow, and that is making you think that the patient is having shock when the other limb is actually having hypertension. So how to approach? You always have to check the BP in all extremities. At least check for the pulse in all of the extremities. Focus to rapidly diagnose aortic dissection or with tamponade or rupture, and your ECG to look for any occlusion on mice. Most of these patients require emergent surgery. If you're not going to take them to surgery immediately, the patient will die, basically. You can temporize the patient with some blood products, vasopressors, whatever you have available, and all of those things to just buy you some time until the patient can get to the OT. And if your patients have tamponade, you can do a pericardial synthesis, again, just to buy time. This is not a permanent solution to the problem, obviously. So that is all about hypotensive aortic dissection. So, in general, when do you intervene for these dissections surgically? So, all type A dissections are to be managed surgically, especially in acute presentations. Type B, generally they say medical management, but if they have certain complications, you will consider taking them for intervention as well. For example, if they end up having a rupture, occlusion of major arteries, like that case we saw earlier, refractory pain or refractory hypertension, these are some indication for intervention in your type B dissections. So prognosis, type A is worse, obviously. With surgery, even with surgery, mortality within 2 weeks is around 20%, which is pretty high. And without surgery, is half the people would be dead. Type B, if only medical management is needed and no complication, mortality is less than 10%. But if it is complicated and needing endovascular repair, the mortality can be as high as 30% also. So even type B dissection can be pretty bad. So there's another thing that we generally don't learn that much, which is a classification of aortic dissection based on time. So we all learn about acute aortic dissection basically, that is presenting less than 2 weeks. So different classifications define the subacute and chronic differently. Some classifications say that it is like 2 weeks to 3 months. Some say it's like 2 weeks to 6 weeks. But which is the difference between subacute and chronic. But basically, once an aortic dissection is beyond 2 weeks, that means that the patient is somehow tolerating that dissection to some extent, and the risk of dying immediately is perhaps not as much as the patient is presenting acutely within a few hours or days. So in these kinds of patients who are having non-acute aortic dissection, so they're presenting more than 2 weeks basically. So what are the indications for intervention? So if they're having recurrent pain or they have a big aneurysm formation, they are propagating retrogradely, then you should consider intervention on them, even if it is more than 2 weeks and it's a bit, not that acute. So this is all about aortic dissections, but these are not the only acute aortic syndromes. Because aortic dissection has a couple of cousins as well, and they can also be troublemakers. So other aortic dissections include intramural hematomas and penetrating aortic ulcers. So this is a difference between them. So aortic dissection, you have an intimal violation and propagation of blood through the media. In intramural hematoma, basically that intimal violation is not there, or maybe it was there, but it's no longer there. So basically, it's a hematoma within the tunica media. Penetrating aortic ulcer, there is a violation of the flap due to an atheromatous aortic plaque. But because of the plaque, there is no propagation of this ulcer anywhere. But these tend to form a circular aneurysm. That is what basically happens. So we'll discuss about these things. So intramural or intramuscular hematoma, which is basically within the wall of the aorta, and it happens usually due to rupture of the vasorum of the aorta. Or it could be because of a tiny dissection which later sealed itself, or maybe a part of the evolution of a penetrating aortic ulcer also. Usually, it is benign, or at least more benign. I think it's better to say it is more benign than an aortic dissection, but it is still dangerous. If you have a type A intramural hematoma, similar classification, type A intramural hematoma can still have a mortality of 30%. So it can still be very, very dangerous. So even though generally it is a more benign thing than aortic dissection, this can also be dangerous and might be requiring intervention based on either its size or location. And a third of these can eventually evolve into an aortic dissection as well. And compared to a dissection, these actually have a higher tendency to rupture because it is actually located on the outer parts of the tunica media near the adventitia. So there is a higher risk of rupture, and it can later on lead on to aneurysm formation as well. Coming to penetrating aortic ulcers, so I already said that occurs when the atherosclerotic plaque erodes into the aortic media, but the plaque itself prevents this from propagating like an aortic dissection does. Usually seen in older patients in the mid to distal descending thoracic aorta. And you can see here in this image, you can see outpouching in posteriorly due to the penetrating aortic ulcer. This generally forms these circular aneurysms. So it can cause IMH, it can cause aneurysms, can cause rupture and dissection as well. So considering both of these conditions together, IMH and PAU, their clinical presentation is going to be similar to your aortic dissection. They're also going to be presenting with acute chest pain, but there is not that much of a migratory pain. So radiation to the back might not be there. And distant occlusion features are also not really there. So limb ischemia, stroke-like symptoms are not very common with these conditions compared to your aortic dissection. Management, acute management, as far as what you have to know is very, very similar compared to aortic dissection, but you'll have to do some serial imaging to look for progression into something that warrants intervention. When do you intervene? Big lesions, IMH of ascending aorta, these things generally need operation because they can be very dangerous. Mortality is high. Enlargement of over time, circular aneurysms or persistent pain, these are consideration for surgery. Obviously, these are things that you will discuss along with either your CTVS or your cardio radiology friends. So finally, take home points. Address score along with the D-dimer can help you risk stratify patients with suspected aortic dissection. The speed protocol is something that will help you while doing a focus on these patients. If you have any kind of significant suspicion for aortic dissection, just get CT angio. Don't rely on other things to rule things out. Try to reduce your heart rate first and foremost, then go for reducing your blood pressure. And always go for early surgery in your type A aortic dissection patients. And these are some of my references. And for those interested, the ECGs were taken from Dr. Smith's ECG blog, and the X-rays were taken from a blog called Dr. Pepe's Diploma on Chest X-rays, both of which are completely free and which are very good for learning how to read ECGs and chest X-rays respectively. So that that is pretty much it for this particular class, and thank you all for joining.